Hey everyone, I'm really sorry for the delay with this video. I've had a busy couple of weeks. So the point of this video is to really reintroduce the basics of renal physiology and lead in to the concepts of acute kidney injury, glomerulonephritis, and chronic kidney disease. Because there's quite a few case protocols and a big part of the biomed exam about renal disease. There's cases about Nephritic Syndrome, Nephrotic Syndrome, vesico-ureteric reflux, chronic kidney disease, and ureteric calculi. And a lot of these terms are really unfamiliar. They were definitely unfamiliar to me when I was doing my biomed year. And I found out really the hard way that I tried tackling these topics without going back and reteaching myself the basic physiology, and they were really difficult. So the plan is, hopefully this video will reintroduce those concepts and make it really easy for you guys to tackle those difficult pathological processes, which everyone, believe me, everyone finds them difficult. As usual, if you have any questions about this video, please feel free to message me, but I hope you find it helpful. So, what's really fundamental to understand before you tackle the kidney is where fluid sits in our body and the fluid compartments that exist. Now, there's a common misconception that the most amount of fluid in our body actually sits in the plasma. That's actually not true. So if we start from the basics, if you take our total body weight, 60% of our body is composed of water, right? So more than half of us is water. And the next place where we sort of divide up where this water fits in our body is inside cells and outside cells. And as you can see, the vast majority of this water sits intracellularly. The remaining third sits extracellularly, and 3/4 of extracellular water is outside our vascular system. So it sits outside our blood vessels, inside our tissues, in the interstitium. The remaining 1/4 is our plasma. So I think fluid compartments can be a very abstract concept, but just get used to compartmentalizing, for better use of the word, where water sits within our body, because it's quite important to understand that when we start thinking about how the kidneys manage fluid balance. So this is a nephron. And the nephron is essentially the functional unit of the kidney. The kidney is composed of millions of nephrons. And the nephron consists of a glomerulus and a tubule, right? So the remaining part is the tubule. And for the kidney to perform its function, which we'll talk about in a second, the first thing that needs to happen is glomerular filtration. Right? And what happens here is blood flows from the afferent arterioles, right? From the renal artery through a number of subsegmental arteries into the afferent arterioles, and eventually will leave via the efferent arteriole, right? In the middle of the afferent and the efferent arteriole is a tuft of capillaries. And what happens is high hydrostatic pressure in this capillary tuft, the glomerulus, forces small molecules such as water, glucose, electrolytes, and urea through the capillary, through the glomerulus, and into Bowman's capsule, right, which is the first part of the tubule. And the parts that get through are called the ultrafiltrate. And remember, we said that includes, from the blood, water, glucose, a bunch of electrolytes, and urea. Right? And then the filtrate moves into the tubules. Now, what we shouldn't forget is that these tubules are very closely related to another set of capillaries called the peritubular capillaries, right? And if the body realizes that it wants to maintain or retain some of the contents of the ultrafiltrate, it's able to reabsorb those contents from the tubules back into the peritubular capillaries. Equally, if there's extra things that the body wants to get rid of from the blood, it secretes things from the peritubular capillaries into the tubules. By the end, if everything is working well, the body has got rid of all the water, glucose, not really much glucose. Normally the body resorbs all the glucose, but electrolytes such as potassium, acidic molecules, urea, and it gets rid of all those things and it sends it down the collecting duct, which connects to the ureters and eventually goes out through the bladder into the urine. And it's maintained all the things it wants to keep in its peritubular capillaries. The last thing I'd like to say about this nephron is just that you should become aware generally about the parts of the tubule. So just be aware, it starts with the proximal tubule, it then goes to something called the loop of Henle, then moves on to the distal tubule, and then on to the collecting duct. Now this isn't going to be like back in first or second year whenever you did renal physiology with Professor Gibson. This time we're just going to look at the absolutely clinically relevant parts of the nephron. So let's have a closer look at the glomerulus, because there has been a past biomed question asking students to discuss or describe the structure of the glomerulus. So just remember, blood comes in through the afferent arteriole, goes into this network of anastomosing capillaries known as the glomerulus, and gets filtrated into Bowman's capsule, which is this capsule around the glomerulus that leads into the tubular system. Now, there's a couple of things I want to mention. The first is, we mentioned what gets filtrated in the last slide. This time, let's talk about what gets left behind and that what shouldn't be filtrated. So, large proteins, your cellular contents in the blood, the red blood cells, the white blood cells, the platelets, these things are never filtrated into Bowman's capsule. And we're going to talk about that in a second, about why exactly that happens. But just remember, if you ever start seeing these things in your urine, that indicates there may be some form of glomerular disease because you're getting things filtrated that shouldn't be filtrated. And the reason the glomerulus produces such a specific filtrate is because it filters the plasma according to size, right? Number one, it filters according to size and it filters according to net charge. How does this all work? It involves us looking more specifically at the structure of the glomerulus. Just to orientate you, this is a cross-sectional view, just like you've cut through a glomerulus, and each of these holes here are loops of capillaries. You can see a red blood cell is drawn inside one for effect, right? So the first thing the glomerulus does is filter by size. And the way it does that is by having these fenestrations in the endothelium. Essentially, fenestra is the Latin word for window. It has very specific holes in the capillary that allows small molecules, the electrolytes, your water, your glucose, to move through, right? Now, the endothelial layer is actually fused to two layers of epithelium. The first is this maroon colored epithelium you can see in between the orange and the blue. Can you see it here? Also comes up here. Just follow this maroon line, which I'm now turning orange. Right? And this maroon layer is called the basement membrane. Now, what the basement membrane is, it's made of something called heparin sulfate, which is actually a negative molecule, and because negatively charged molecule. And because proteins are also negatively charged, this repels proteins from moving into the ultrafiltrate because of negative charge repulsion. Right? And then finally, under the basement membrane is a second layer of epithelium that's very closely adherent to the endothelium, and that's called the foot processes. Right? They're podocytes with foot processes. And this diagram actually shows it quite well. So you've got your capillaries here of your glomerulus, you've got the endothelium, and these things demonstrate the fenestrations. The endothelium sits on top of the basement membrane, which is made of heparin sulfate, and it's your charge barrier. And finally, you've got a visceral epithelial layer consisting of podocyte foot processes, which are these blue things. The key point to remember is that the glomerulus is a filtrate. It's a filter, and it filters based on size and net charge. So just to reiterate, the function of the glomerulus is to form an ultrafiltrate, nearly free of protein and completely free of cellular elements. And this ultrafiltrate flows into the renal tubules. The function of the tubules is to reabsorb and secrete solute or water from the ultrafiltrate according to the body's needs. So what are the functions of the kidney? Well, the kidney regulates the balance of fluids and electrolytes in our body. And the way it balances fluid in our body and regulates this is through two main pathways that you should know about. There's the renin, angiotensin, aldosterone axis. And remember what aldosterone does? It acts on the distal tubule and the collecting duct. And remember, aldosterone is a mineralocorticoid. What it does is it increases the resorption of sodium back into the peritubular capillaries. Because you get resorption of sodium, the water follows the sodium and it increases the resorption of water. Right? And that sodium that it resorbs is actually exchanged with potassium. So it's good to be aware of that. The other big pathway that the kidney uses is the pathway to do with antidiuretic hormone, also known as vasopressin. It's released in the posterior pituitary gland, right? And it acts in the collecting duct as well. But this time, it adds channels called aquaporins on the collecting duct to increase the resorption of water into the peritubular capillaries. Right? The kidney is also very important at regulating the acid-base balance. It excretes a number of nitrogenous waste products, particularly urea. It's important in regulating blood pressure, largely through the renin-angiotensin axis. And don't forget, it has a number of endocrine functions as well, right? So it actually, I look at all these things as homeostatic functions, right? Maintaining a constant internal environment in the body, but it also has endocrine functions, and this involves hydroxylating vitamin D. Now, that activates vitamin D into its activated form and allows it to function and increase the absorption of calcium in the gut, right? It also secretes erythropoietin that stimulates the bone marrow to start producing red blood cells, erythropoiesis, right? And renin is another hormone that it secretes, right? Going back to the RA system, from the juxtaglomerular apparatus. We'll go through where that is in a second, and that's involved in blood pressure control. And remember, for us as clinicians who are going to be prescribing a lot of drugs, we need kidneys to excrete the drugs we prescribe. Glomerular filtration rate is an extremely important concept to understand. The GFR, you'll see it ordered all the time on Power Chart. What it reflects is the volume of fluid filtered by all the glomeruli in the kidney per minute, and it's measured in milliliters per minute. Now, it's very important to be able to understand how we derive our glomerular filtration rate. What formula do we use? How do we actually find out this value? And the way we find out this value is through the concept of renal clearance. Right? And the rate of clearance of a substance X, right, is equal to the urinary concentration of that substance multiplied by the urine flow rate, represented by V, divided by the plasma concentration of X, right? And why this formula works is that the plasma concentration of X multiplied by the clearance rate of X has to equal the urinary concentration of X times the urine flow rate. So if you want to find C, the clearance rate of X, you divide all this by Px, the plasma concentration of X. That's why this formula works. Now let's take a step back from that. If the clearance of a substance is less than the GFR, right? Then there must be some reabsorption of that substance in the tubules. If the clearance of a substance is greater than the GFR, then there must be some secretion from the tubules, from the capillaries into the tubules of that substance X. If the clearance of a substance equals the GFR, then there is no net secretion or reabsorption of that substance. I hope that makes sense. If it doesn't, please message me. I know it can be a difficult concept. I'm more than happy to talk about it. But it's a very important concept because it leads to our derivation of the GFR. So inulin, not insulin, inulin is a substance that is actually not reabsorbed or secreted in the tubules. So, if we can find out the clearance rate of inulin, knowing that it's not reabsorbed or secreted, we actually can derive the GFR. So what's the clinical value of inulin? Well, inulin is the gold standard for calculating glomerular filtration rate. And how this is typically done, it's actually rarely done in hospital, as I'll talk about in a second, is you don't actually have inulin in your body naturally. You infuse a known dose of inulin into the patient to establish a plasma concentration which you understand, right? So you establish a plasma concentration of inulin, and then you measure the urinary concentration of inulin and the flow rate of urine. This calculates the clearance rate of inulin, which reflects the glomerular filtration rate. This is rarely done clinically, and in fact, the substance that we use to measure GFR rather than inulin is creatinine. So, creatinine is a non-toxic breakdown product of creatine. This is a short-term energy store found in muscle. A lot of you may know, just on a quick side point, that a lot of people who are bodybuilders or weightlifters use creatine supplements to help build muscle. And the way this works is simply by providing more short-term energy stores, allowing them to lift more weight. That way, they are not deriving their energy stores from destroying muscular proteins. Okay? And creatinine clearance, getting back to the point, is an approximate measure of GFR. It's almost like inulin. But why it's not as good as inulin is because it slightly overestimates the GFR because it's moderately secreted by the renal tubules. But it's pretty good. And in fact, most of the GFRs that we derive clinically are based on creatinine. Now, the other problem with creatinine is that it is high in high muscle mass patients, patients with muscular dystrophy and acute muscular necrosis. And in fact, I was in ICU last week and it is low in patients. I was asked why it would be low in patients, and one of the patients we saw was caexic. He was weighing 37 kilograms. So in these sort of patients, they have less muscle mass, so their creatinine's low. And the other one was a quadriplegic. So in this patient group, the creatinine is also low, and hence not really reflective of the glomerular filtration rate. So as I said, when you're calculating the glomerular filtration rate, inulin clearance is the gold standard. Creatinine clearance is the next best thing, but we don't actually calculate GFR this way. If you've noticed, we rarely ever measure the urinary concentration of creatinine or the urine flow rate. That would just take way too long. So what we do is something called the estimated GFR. And the estimated GFR is based on two potential formulas that we use. In our hospital, we use the MDRD formula, right? And the thing with this formula, we'll talk about this first, is it doesn't include the patient's body mass. So as I was mentioning, for those patients who are particularly high in muscle mass, larger individuals, it doesn't take that into account. Equally, it doesn't take into account caexic patients. And it measures it by a formula, which you don't need to remember, but you do need to remember that it exists and that it doesn't take into account body mass, so it can't be wrong. Can't be perfect. The other formula that you can use is slightly better. It's called the Cockcroft-Gault formula. And this actually does take the patient's body weight into account. So it's slightly better than the MDRD formula, but it relies on you weighing all the patients in your hospital. And that's why I think we don't use it in our hospital. But this has been a past biomed question, and they have asked, essentially, how do you calculate the GFR? So if I was asked that, I would start by talking about the gold standard, which is inulin clearance. And if you're confident, tell them about the formula for clearance and derive it for them. But then say this isn't very practical on measure when we have so many patients. So we use creatinine clearance, and rather than measuring urinary concentration of creatinine and urinary flow rate, we have two formulas. These are the two formulas. One includes body mass, one doesn't. We use the one that doesn't, and that's called MDRD. Hope that makes sense. I bring it up in such great detail because they do like to ask about this. The next concept I think is important to mention is acute kidney injury. Now, how do we tell that the kidney may have been injured? Essentially, you have to look at two things. One, the urine output, right? The urine output, as you probably can understand now, is a direct reflection of the GFR. And the second thing, which is also how we derive our GFR, is the serum creatinine. So if we have a drop in urine output and an increase in serum creatinine, it is very indicative that there has been some, and this has occurred acutely, it's very clear that there has been some form of acute dysfunction of the kidney, which we call acute kidney injury. Now, how do we quantify this scientifically? I'll tell you, the first thing is, normally, clinically on the ward, you simply look at these two parameters. Clinical research and academia has derived two tools which are rarely ever used in clinical practice, but do define exactly what we mean by a drop in urine output or an increase in creatinine. And these are good to mention in exam answers. They sound very professional and very thorough. So there is the rifle criteria for definition of acute kidney injury, and it essentially stratifies how severe the kidney injury is by the degree of increase in serum creatinine. An increase in serum creatinine by 1.5 suggests you're at risk of kidney injury. By 2 of baseline suggests you are in acute kidney injury. A serum creatinine that's 3 times its baseline suggests you're in renal failure. And then you can talk about later stages of kidney disease. Similarly, if you have a urine output which is less than 0.5 mils per kilogram per hour for 6 hours, it sets you at risk. 0.5 mils per kilograms per hour for 12 hours, it says you're an injury. And 0.3 mils per kilogram per hour for 24 hours, or anuric for 12 hours, suggests you're in renal failure. The Akin does something similar. I would suggest you are be aware of these two things. If you'd like to, remember one of the two. But a very important value, I think, to remember clinically is this value of less than 0.5 mils per kilogram per hour of urine output. It is the definition of oliguria. So why do we get acute kidney injury? And what's a way we can divide the causes of injury to the kidney? Well, the way to divide it is by thinking of causes that are pre-renal, intrinsic to the kidney itself, and after the kidney. Pre-renal causes are due to reduced perfusion of the kidneys, right? And as we talked about a few weeks ago, reduced perfusion can be the result of shock. It can also be not to the extent of shock, but just due to simple dehydration. It can be due to the use of certain drugs, such as diuretics, NSAIDs, ACE inhibitors, or angiotensin receptor blockers, ARBs. You may remember these as the triple whammy, and we're going to talk about this in a second, the mechanism of it. And what you should be aware is that pre-renal acute kidney injury is the most common cause of acute kidney injury in the hospital. It is quite often due to dehydrated patients, patients who are septic, patients who are in shock, or patients on drugs such as these that reduce the glomerular filtration pressure. Acute kidney injury can also be due to failure from the kidney itself, right? And when you're talking about the kidney itself failing, the failure can happen in the glomerulus, which is reflected by glomerular nephritis, or it could be in the tubules. And there's a disease or pathology known as acute tubular necrosis, and that can be because of severe pre-renal causes. If you have reduced perfusion of the kidneys, so much so that you have ischemia of the kidneys, the most metabolically dependent part of the kidney is actually the tubules, which has a number of pumps and channels that require a lot of perfusion and a lot of ATP to keep them functioning. You will get death of those tubules. Acute tubular necrosis can also happen due to toxins such as radio contrast. It's very important before you order a CT scan with contrast to get an idea of the renal function of a patient. Due to myoglobin. Myoglobin is actually a part of muscle, but in patients who have crush injuries, traumatic injuries, or who have been lying on the ground for long periods of time and they have muscle breakdown, myoglobin leaks from the muscle into the circulation, into the kidneys, and causes necrosis of the tubules. Hemoglobin in hemolytic anemias, radiation, and again, nephrotoxic drugs. All these toxins can cause acute tubular necrosis. You can also have interstitial nephritis, and that's often due to drugs as well. So this is an inflammation of the interstitial tissue around the peritubular capillaries, and drugs such as penicillins, cefalexin, and PPIs can cause this. Right? And post-renal causes of an acute kidney injury are essentially due to an outflow obstruction of the kidney. So, if you have ureteric stones, remember, you have to have bilateral obstruction normally to get a renal injury, because the other kidney can normally compensate for the kidney that is obstructed, if that makes sense. So the stone normally has to be in the ureter rather than in the urethra rather than the ureter, or in the neck of the bladder, so it's obstructing both kidneys. Benign prostatic hypertrophy, prostatic neoplasia, or congenital strictures of the ureter can cause post-renal obstruction of kidney outflow and hence kidney injury. And the mechanism behind the kidney injury in these patients is a backflow of the urine. Say these are the ureters, emerging from the kidneys into the bladder. If you have too much pressure, you get a backflow of pressure up here, and you get a growth of the kidneys because of the pressure, known as hydronephrosis, water in the kidneys, and that hydronephrosis leads to acute kidney injury. And the treatment for hydronephrosis, if you can't relieve the obstruction, is a percutaneous nephrostomy. That's an interventional radiological guided procedure where they simply stick in catheters into the kidney to drain the fluid, a percutaneous nephrostomy. So let's talk a little bit more about the triple whammy. Clinicians are really quite aware of this notorious drug-drug interaction, but because it's such great physiology behind why this combination of drugs produces a pre-renal injury, examiners love asking about it to test your knowledge. So remember, the three drugs are a diuretic, an ACE inhibitor, or angiotensin receptor blocker, or a non-steroidal anti-inflammatory drug. And this combination of drugs is obviously very prevalent and indicated in an elderly patient who might be hypertensive with heart failure and who may have an element of arthritis or some sort of chronic pain. So it's just a very common combination of drugs that may be prescribed. Now, why does it lead to renal injury? Well, it's all due to the concept of intraglomerular pressure. As you can imagine, if you lower your intraglomerular pressure or your glomerular hydrostatic pressure, you have less glomerular filtration. And less glomerular filtration lead to less urine output. Less urine output means that you are retaining your nitrogenous compounds, your acidic substances, electrolytes such as potassium, and essentially you get all the manifestations of an acute kidney injury. We're going to talk about that more in a second. Now, why does this happen with these three drugs? Well, the diuretic, what's that designed to do? Well, the diuretic is going to reduce your intravascular volume. Right? The diuretic, by doing that, decreases your intravascular volume. Because you decrease your intravascular volume, you decrease your end diastolic filling pressure, which is also known as your preload. Because of that, your stroke volume falls. Because of that, your cardiac output and your blood pressure falls. And because of all that, your renal perfusion falls. That should be a P. Right? So we figured that one out. What about your ACE inhibitor or your angiotensin receptor blocker? Well, angiotensin usually constricts the efferent arteriole. The effect this has is to raise the glomerular hydrostatic pressure. You can imagine why. If you constrict this, there's more pressure back transmitted into the glomerulus, increasing your glomerular hydrostatic pressure. However, with an ACE inhibitor or an ARB, what you have is a loss of this constriction and as a result, a loss in your increase of glomerular hydrostatic pressure. Now, NSAIDs, what they do is they reduce the secretion of prostaglandins. Now, prostaglandins are actually responsible for dilating the afferent arteriole. And as you can imagine, this also, because there's more blood coming into the glomerulus, actually increases the glomerular hydrostatic pressure. But if you block the production of prostaglandins by giving NSAIDs, you block this afferent arteriolar vasodilation. So by giving these three drugs, you essentially drop afferent arteriolar vasodilation, stop efferent arteriolar vasoconstriction, decrease your circulating volume, and as a result, you lose your glomerular hydrostatic pressure and decrease your glomerular filtration rate, leading to a lower urine output. This is how the triple whammy leads to acute kidney injury. So we've talked about what acute kidney injury is. We've talked about why it could occur, but what are the consequences of acute kidney injury or renal failure? Well, it's quite straightforward, because if you remember back to the functions of the kidney, you simply get dysfunction in all of its functional capacity. And before we get onto this list, I remember Dr. Spicer gave us Acute in phase 2, and he said there's three things that are going to kill your patient with acute kidney injury, and they're the things you need to look out for first. The first involves a dysregulation in your fluid balance. You become fluid overloaded if you can't get rid of your fluid, if your kidneys aren't working, and if you have too much fluid in your body, it goes from the intravascular compartment into the interstitial tissue and then into the cavities. And so he mentioned that pulmonary edema is the first thing that can kill you. The second thing is hyperkalemia. Right? Too much potassium in the blood. As you know, potassium can affect the myocardium if there's too much of it and cause fatal arrhythmias. And the third is too much acid in the blood leading to acidemia, a metabolic acidemia. So he said these are the first three things you need to look out for if you have a patient in acute kidney failure. And also quite a big red flag, two of these things present with shortness of breath. Right? The acidemia presents with shortness of breath because the patient is trying to compensate for their acidemia by hyperventilating, and the pulmonary edema, obviously, because there's fluid in the alveoli, the patient is trying to breathe more often to get more of a tidal volume to diffuse more oxygen into their blood. But essentially, if we go through this list, the inability to make urine and excrete nitrogenous wastes leads to these manifestations: fluid overload because of sodium and water retention, hyperkalemia, metabolic acidosis, and azotemia. Now, azotemia is a word they love using in American textbooks. It's essentially because of an inability to excrete nitrogenous waste, so blood, urea, nitrogen. And that has its own effects. It can lead to pericarditis, it can lead to asterexis, which is more of a clinical sign, not a problem, encephalopathy, and platelet dysfunction. So, we talked about the causes of renal injury, and we broke them down into pre-renal, renal, and post-renal. Renal, we talked about, could be because of the glomerulus or because of tubular interstitial problems. And now we're going to focus on what the first couple of case protocols focus on is glomerular injury, right? And glomerular injury is known as glomerulonephritis. It's a misnomer. It is really a glomerular nephropathy. Glomerulonephritis seems to indicate that these are inflammatory processes when some of them are, but some of them aren't. So think of them as glomerular nephropathies. And pathologically, when you're breaking down glomerulonephritis, break it down into proliferative and non-proliferative processes. And we're going to talk about this in a second. And clinically, break it down into a nephritic or a nephrotic syndrome. Now, these words were very new to me last year, and this video is all about introducing them to you in a gentle way. Just remember, proliferative pathology normally correlates with a nephritic syndrome, and non-proliferative pathology normally correlates with a nephrotic syndrome. However, you should be aware that these are spectrums and these rules don't always hold hard and fast, but to start with, and indeed for the purposes of your exam, if you equate these two things and explain them well, you will do very, very well. So let's talk about proliferative pathology and nephritic syndromes. This is the subset of glomerulonephritis that is actually an inflammatory process, nephritic, right? And what it involves is a proliferation of cells around the glomerulus. Because you have a proliferation of cells, now these are inflammatory cells, leukocytes, PMNs, lymphocytes, they reduce, all these cells make their way into the glomerulus. They reduce the filtering area of the glomerulus and also cause vasoconstriction of the afferent arterioles because of the inflammatory leukotrienes. Because of these two things, you get a reduction of glomerular perfusion. If you have less glomerular perfusion, you have a retention of sodium and water, right? And that leads to hypertension, right? Now, because you're getting a reduced filtration rate, there's an activation of the renin-angiotensin system. The renin-angiotensin system really gets activated when the glomeruli, the cells around the glomerula, remember the juxtaglomerular apparatus, detect there is less filtration occurring. So the renin-angiotensin also gets activated, and that, as you know, releases angiotensin, which is a vasoconstrictor, releases aldosterone, which will resorb sodium and water, and only exacerbate the hypertension that is already occurring. And so, the hallmarks of a nephritic syndrome are hematuria, and this is occurring because of the inflammatory process that is centered around the glomerulus. What happens is, because of the hypercellularity, red cells make it through the glomerulus into the tubule system and come out as blood in the urine. Classically described as Coke-colored urine, Coca-Cola-colored urine. You get oliguria because of the decreased filtration area, remember? And you get hypertension because of the retention of sodium and water. Because of the reduced filtration in general, the decrease in GFR, you get a retention of nitrogenous compounds and azotemia. And because of the destruction of the glomerulus and the glomerular basement membrane to an extent, you get a mild to moderate leakage of protein into the urine. These are the 5 hallmarks of the nephritic syndrome. You will remember them if you understand the pathological process of proliferative glomerular disease. This comes up very often, and this is the main part of understanding glomerular nephritis in terms of nephritic syndromes. Let's talk about non-proliferative and nephrotic now. So this subset of glomerulonephritis is not inflammatory in nature, and it relates to a profound disturbance of your glomerular basement membrane. Remember, that's the level of the layer of epithelium that your endothelium sits on. And that's the thing that's made of heparan sulfate and normally has a negative charge that repels the proteins. Now, for some reason, and we'll talk about these more in the tutorial, in these diseases you get a disturbance of your glomerular basement membrane. And because you have a change in glomerular permeability, you start losing protein molecules into your urine and you lose albumin. Now, if you lose albumin, you lose your plasma oncotic pressure and you have fluid which used to be held in the intravascular compartment by that plasma oncotic pressure moving into the extravascular compartment. Because of that, you get a decreased plasma volume that intravascularly deplete, but extravascularly they're edematous. Right? So the depletion of the intravascular volume will cause reduction of perfusion of the glomerulus. that will activate the renin-angiotensin system, sodium retention, fluid retention. But because you're retaining, just because you're retaining fluid doesn't mean it's staying in the blood vessels, because your decreased plasma oncotic pressure will move it into the interstitial tissue and give you edema or anasarca. Now, the other thing that happens, because you have less protein in your blood, your liver tries to compensate for the loss of albumin by regulating its production of another protein, low density lipoprotein, and that gives you hypercholesterolemia, right? So then the other thing that happens is, because you're not only losing albumin, you're losing antithrombotic proteins such as protein C, protein S, angiotensin, antithrombin 3. Remember, protein C and S are antithrombotic because they break down factor V. And antithrombin 3 is the regulator of the coagulation cascade. You are at risk of a prothrombotic state. And finally, because you lose immunoglobulins, another form of protein, you are susceptible to infection. So, a nephrotic syndrome is characterized by a proteinuria of more than 3.5 grams per day, or an albumin to creatinine ratio of over 300 to 350 milligrams per millimole. You can define a nephrotic syndrome by either of these proteinurias. Albumin to creatinine ratio is easier to calculate because it's a one-off ratio rather than trying to measure protein for the whole day in urine. The next thing that happens because of the loss of protein is hypoalbuminemia. Because of hypoalbuminemia, you have intravascular volume losses to the extravascular space, leading to whole body edema, known as anasarca. Because the liver tries to upregulate the lost proteins, it increases the production of low-density lipoproteins, leading to hyperlipidemia, and those proteins end up in the urine too, leading to lipiduria. You also have the potential for thromboembolic disease because you lose antithrombotic proteins such as protein C, protein S, and antithrombin 3. And because you lose immunoglobulins, you are prone to infection. That is the nephrotic syndrome. These are the 6 hallmarks of a nephrotic syndrome. And again, you will remember them by remembering the pathophysiology of non-proliferative glomerular disease. So guys, thank you so much for watching the video. I think it is so important to understand these concepts, because if you understand these, the case protocols, the exam questions will be no issue. I know there might be some questions. I understand this is a complex topic. I am more than happy to talk through these things with you over the next few weeks and get this topic out of the way as well early, so there's no late stresses before the exam about this. Let's knock it out of the park. See you later this week.